Hello, everyone. So happy to be here discussing with Ravi and learning from him and taking some help from him because I probably need it from a case from Mark. But so happy to be here. We can start when you want.
Thank you, David. I know people are wondering a case from Mark. If you haven't checked out any of Mark's four, right? Yeah, this is the fifth one. Oh my gosh. Previous four cases, it's always a doozy. So welcome. Before I pass the mic to Mark, harder to say than I thought. I just wanted to share with you all. I'll steal the screen from Mark Source in a sec. Share with you all a very, very important and really cool thing. People as talented as Mark, who you'll see, and his colleagues are helping you all put your cases together. I will keep plugging the case review committee because I've learned that the more we talk about it, the more that people feel inclined to submit. But if you have a case as simple as a UTI or as complicated as relapsing polychondritis with tracheal involvement, please consider submitting it here. You know, we all have amazing cases and we try to submit them to peer-reviewed journals, and that's one great way of making an impact. But that doesn't preclude you from also submitting it here. So these case presentations are compatible with most journals, and you're pretty much not you're not facing an uphill battle for us to hear your case. In fact, you're going to be met not with the reviewer, but with somebody who is hoping to actually help you succeed and put the case together. So the instructions are here for you to look at. We really recommend it. We've had over 40 people present their cases since we started this initiative 3 months ago, and we're really hoping that you all get to benefit from the skills of putting a case together with the mentorship of the brilliant people in the CP Solvers Academy, and that we as a community get to learn and grow from your case. So it's a great opportunity for everybody to learn and grow, and really hope you jump in. All right, with that, we will set the bar very high with Mark. And so we'll give Ashutosh a second to steal back the screen. And then whenever you're ready, Mark, take it away.
Awesome. I can't wait to learn from you guys. It's going to be a lot of fun. All right. So for our patient, so this is during my VA rotation about a week and a half ago. So we have a 62-year-old male who presents with 2 days of generalized weakness and lower extremity numbness and 1 month of polyuria and polydipsia.
Okay. So well, generalized weakness is a very broad concern, and I feel that its difference is very big. I think we have to detail a little bit more if what is this weakness meaning. If it's true weakness or due to muscle involvement, like some problem in the neuromuscular system from the cortex to the muscle, and involving all the structures in the middle, and also electrolytes abnormalities such as hypokalemia or hypomagnesemia, hypokalemia, something like that. In here, the low extremity numbness make me think that maybe it has to be with a neurologic problem, maybe in the spinal cord, or maybe in the something like a polyneuropathy. But I'm not sure about the time course. If this hopefully Mike could tell us more if this numbness started at the same time of the weakness, or if they are independent. And the 1 month of polydipsia and polyuria make me as immediately in diabetes, either diabetes mellitus or also insipidus diabetes. But I don't know for the moment how to relate those two problems. Um, I don't know. I think we could frame it like independent problems, or maybe an underlying cause causing both pollution, polyuria, and generalized weakness, or another possibility, which is polyuria causing some electrolyte abnormality that after could cause the generalized weakness. But I don't feel that will be the case in here, and I feel there will be like an underlying problem. I don't know what. But what do you think, Ravi? Please help. I yeah, I can see you.
I don't think you need help at all. I think that the truth is all of us are probably rushing to thinking what's going on, but I want you all to stop for a second and ask yourself, what would you be thinking if a patient said these things to you in the first minute? And I think that unfortunately you stand on very loose ground, because many people feel like they drink a lot, pee a lot, and have numbness and don't feel right. So this is a very, very, very loose sand for us to stand on. And I think you have to ask yourself, what do you worry about the most in this circumstance? And I think that exactly what you said, David, I think the neurological dimensions of this take severe initial precedent. And you have to assume that this is either, you have to assume this is a neurological event that is happening fairly quickly. And it could be a neuropathy as suggested by the numbness, but it's not going to be a typical neuropathy because it breaks one of the few rules of the common types of neuropathy we see. And the common types of neuropathy we see are that it is symmetric, which this doesn't break, it's both legs. Sensory predominant, which this doesn't break, but it finally breaks the other one, which is it's slowly progressive. So 3 S's. Symmetric, sensory predominant, and slowly progressive. And anytime that one of those rules is broken, you're either dealing with an atypical neuropathy or a mimicker of a neuropathy. So always remember the 3 S's. The reason I would be paying very close attention to this patient is not so much the polydipsia and polyuria, because I feel like many, many people will report that, and it turns out that they do what I do and what Deborah does. And we both probably would report this complaint as part of normal life. So the reason I think I'm really worried about this is this really breaks the rule of the 3 S's. While this is sensory predominant and symmetric, it is not slowly progressive. And so I guess the question for you, David, is what kinds of diagnoses would you be most worried about? And what are you hoping to get as next data focusing on that dimension?
I don't know. I want to know if there's any more symptoms, specifically like any symptom or sign pointing towards inflammation that I don't think it will be the case here. The 1 month history of polydipsia and polyuria. I want to know also if there is associated weight loss or clarivision or something like that could point toward and start of diabetes mellitus. Also, well, first of all, asking him or her how much he drinks and what
Excellent.
and what does he drink, and well, I think I want to and so on, but one. I think the labs will give us some information regarding electrolytes abnormalities that could be the real issue here, or could be totally different. But yeah, also very concerned about the labs and the new.
Amazing. You're pulling a Shema where you're answering every question so accurately and well. And so I'm going to ask you and the crowd, to practice something really important. This patient says those words to you, and traditional medicine would have you say you should then now get a full story from the patient and a full history and a full social history. That's what traditional medicine would teach you, but you shouldn't do that. I would argue that you need 2 pieces of data that you should obtain in the next 1 minute that may not be in order. So for everybody in the crowd, take the next 30 seconds to ask yourself, what 2 pieces of information can you get in this patient in the next 1 minute that are more important maybe than the order in which we usually collect data? So David, if you could get anything you want that is available in 1 minute, what would you be inclined based on your instinct? And we can practice that. What do you think?
Well, one thing that may be a silly thing, but with the concern of generalized weakness is I would want to see how the patient is coming to the hospital or to the clinic. Like, is he able to walk, or is he coming on a wheelchair, or what? To
I love it.
Have a sense of the degree of that weakness, and if it's through muscle weakness or that. This is my first thought.
What's your second one?
I don't know. If this would if just for getting a sense of if this would be a really true generalized weakness, and that could worry me. The next thought will be if he's breathing well, to make sure that the problem is not, for example, an ascending paralysis that could affect the muscle, respiratory muscle. But that would be more advantageous.
I love it. You're making very explicit something that is really important, which is when you're first observing a patient and seeing them come in, you have to let the scene wash over you. You have to like let it hit you. How did this person come in? Are they having any difficulties breathing? Are they like, you have to just observe the scene in front of you and let it wash over you. I think 2 pieces of data that you have to actively retrieve that I would get would immediately do reflexes right away. Because if there's no reflex, this is Guillain-Barré until proven otherwise. And if there's hyperreflexia, this is a spinal cord issue until proven otherwise. And that would change my thinking in the moment, right then and there. I don't care what else the medical history is. You know, that moment changed everything. And then a point of care glucose, because if it's 700 or 32, very, very quickly, I make a lot of progress. So I agree with you. I think you need to study the scene. How did the patient get here? How do they look? And the 2 pieces of data that I would want right away in the next minute are, what are the reflexes and what's the glucose? That is available to us in a minute with a point of care glucose and with a reflex hammer. Though I'm lying, I don't carry around a reflex hammer, so I'd probably use a stethoscope in real life for a reflex hammer, but maybe could go get one for this this specific patient. All right, Mark, I think we've talked about this for 15 minutes, so please tell us more.
Beautiful discussion. I'm going to be very authentic to how this played out in real life, because I think it just highlights just the beauty of medicine, honestly. So we get this history paged out. This patient has absolutely nothing in CPRS, the VA EMR, so hasn't been in contact with the medical system, we learned, since he was about 20. So no known past medical history, not any meds that we know, no allergies, no known family history. We see that, at least from the quick chart review, from the triage, that he lives with his brother in Philadelphia. He's retired, and no known health-related behaviors at all. So I'll say that my wonderful intern, Robert, went down to evaluate him, and then I went to admit another patient. And then probably like 5 minutes into admitting the other patient, Robert calls me on the phone. He's like, "Hey, Mark, I'm really worried about our new patient. He looks really ill. He's like desaturating. Can you mind just coming by and see him?" So I go in and see him, and then so I'll tell you my initial exam. So he's afebrile, blood pressure is normal, Heart rate is normal, and he's satting low 80s on room air. So we put him on nasal cannula, and he responded to nasal cannula. He was about on 5 liters. And on his neuro exam, he was AOA times like 1 to 2. He knew himself, but not where he was, and didn't know the year or the day. He had diffuse myoclonus. His upper extremities and his hands and feet were just twitching. And then when we got the blood pressure, he actually had carpopedal spasm when we inflated the blood pressure as well on both sides. I listened to his lungs. He had crackles in his right lower lobe. Cardiac exam, I didn't appreciate any murmurs. His belly was soft, non-tender, non-distended. His strength, he was probably at, I'm sorry, I'm going a little out of order. His strength, he was probably 4 out of 5 in all extremities, no focality to that. His reflexes, I did use my stethoscope as well. And I got mild hyperreflexia at his patellar tendons bilaterally. And then I just did, I'm a big POCUS enthusiast. So just given he was hypoxic, I did a bedside POCUS, and the windows were difficult, but I thought I appreciated just a globally reduced ejection fraction. But I will say his JVD was not elevated, and he had no really edema in his lower extremities. And just to stay authentic too, we did get a point of care glucose that was 496. So I know that was a lot, but I'll end there.
What do you think, David?
Okay.
It's tricky.
So well, first of all, I'm deeply concerned about this patient, and would probably immediately do 2 things: an EKG and I don't know if an ABG that could show the calcium or ionized calcium, or if not, labs, normal labs that with urgent labs to know the calcium because of the carpopedal spasm, and the myoclonus that I don't know, probably without the clue of the carpopedal spasm while measuring the blood pressure, I wouldn't think immediately of hypocalcemia. I think it's like I associate those two like immediately, and I don't know if there's other associations, but this is the first thing I would be concerned. The saturation and the crackles. I don't know if what to make of it, because well, we don't know the past medical history, but I think the crackles are not many times are not the biggest clue to one thing, because in many cases they are like current or they stand there without meaning an acute pathology, and as we don't know the past medical history, maybe they are there and not meaning something acute, but also we will take a chest X-ray to show to look for that. I haven't thought, I haven't listened if in the focus exam there were any B lines in the basis or in other parts. I think no, but that's another possibility to check for that. But one, and I'm more concerned now about hypocalcemia and probably secondary manifestations of that. I don't know if hypocalcemia could cause anything like respiratory muscle involvement, but as it could cause tetany, I think maybe one of the the manifestations could be that. So also interested in like the CO2 in the VBG or the ABG, and concern for this like being an impending respiratory failure, and that would probably need some kind of support independent of low flow oxygen. And well, that's mainly my thing.
Sorry, Nar, this was causing some menace at the end there, but I heard your discussion, I promise. This is tricky, right? And I think that I completely agree with everything you're saying and the threads that you're going down along. And I think in real life, I would just be trying to separate things. So we have a concern for electrolyte issues for which we have proof with the hyperglycemia and then concern with the myoclone. So I feel like my mind is putting myoclonus, carbopetal spasm, and hyperglycemia in this metabolic domain. But that needs more data to sort of clarify. And then I think the crackles and the pulmonary dimension are completely separate in my mind. So for me, similar to you, David, I'm very clear in my mind about not trying to connect the dots right now, because if you try to connect them, you may miss important information. So for me, there are two separate problems this person has, and we'll try to unify them. The first is hypoxemic respiratory failure with findings of intraparenchymal lung involvement. That's one problem. Curiously, that problem isn't accompanied by the common features associated with that, which is fever or signs of inflammation, to suggest that that lung involvement is an infection, but those things are of limited sensitivity. The other thing that's curious is this isn't accompanied by overt evidence of volume overload. There's one hint at that possibility of the POCUS findings, but no other corroborating evidence. So it's curious that this hypoxemic respiratory failure is occurring in the absence of inflammation and volume overload, but we know that we need more specific signs and data to eliminate those common causes. But that's what makes this case intriguing. Add in a fever or add in a JVP, and I think we'd be able to tuck in that problem, or at least make progress on it. So let's keep trying to build the data for each of those problems. And then we should try to at some point explicitly say, when can we start to link them? But for now, I don't think I have the cognitive ability and the experience to link them. So I'm keeping them separate. All right, Mark, tell us more.
Awesome. So next, in that kind of decompensation, we got a chest x-ray that showed a right lower lobe opacity, but no pleural fusions, interstitial edema, or any other signs of volume overload. We also got an ABG as requested that showed an ionized calcium of 0.7, which this is in millimoles per liter, so rather low. And then after we stabilized the patient, we got some basic labs. So some basic labs show a white blood cell count of 15.7 with neutrophilia, a hemoglobin of 15.7, a platelet count of 357. BNP is notable for a sodium of 133, a potassium of 5.4, a chloride of 96, a bicarb of 28, a BUN of 45, a creatinine of 1.86. And like I mentioned, there's no records in the system, so we are unclear of baseline lab values, an anion gap of 9, and a glucose on the BMP of 486. An A1C came back a few days later of 9. His calcium, not the ionized, but his serum calcium was 7.5. Magnesium was 2. Phos was 5.2. His LFTs were notable for an AST of 90, an ALT of 42, a T-billy of 0.7, a direct billy of 0.2, a total protein of 7.5, an albumin of 3.5, and an alk phos of 67. He had a CK, which was 1941, a UA, which was bland, a BNP, which was 35, and an ethanol and urine drug screen that was negative. And that's the end of this alkaline.
Excuse me, Mark, could you repeat the white blood cell count?
It was 15.7 with predominant neutrophilia.
Okay. that could be a sign of inflammation, but don't know how to explain that. For now, I think there's no clinical signs of inflammation, and the only the only way to relate it to other abnormalities for now are the right lower velocity that could be well, pneumonia. Patient seems to don't have dyspnea or fever or other symptoms. But, well, it's with hypoxemia, so that could explain that. For the rest of the labs, I think that the most striking one is maybe the creatinine. We don't know how long is he been with this renal failure, and with the polydipsia and polyuria history, this could be just like type 2 diabetes patient with renal CKD from diabetes, but also would be an AKI from like hemodynamic AKI in this setting. And I think in the labs there were also sodium was 133 and potassium 5.4. That when I see that combination, that made me think of adrenal insufficiency, causing hyperkalemia and hyponatremia. That in this setting, I don't know if I think it won't be the main like DDX, because it could the potassium could be, the hyperkalemia could be explained also by the AKI. And well, the calcium is low, but not so low. I think it could explain the myoclonic and the carpopedal spasm, and probably the generalized weakness. And I don't get much information for that. I think the main question here are 2 or 3 that are why is he with hypocalcemia? Why does he have what seems to be diabetes related with that hyperglycemia and cardinal symptoms? And what do we make of this respiratory failure with the right lower lobe? Not sure how to relate those 3 problems. Not sure. I think well, we need probably a PTH to think more of the hypocalcemia, but I'm thinking of like combined endocrinopathies that could explain this, but I'm not sure. The autoimmune polyglomerular syndrome type 1, it could be a cause, but I don't know. We need more information.
Yeah, please. I love that. Trying not to diagnose autoimmune polyglandular syndrome. Only David would be able to with this amount of data. But I'm glad it's on your radar, because this. Let's just be real. What is the salient feature about this case? The complexity of the metabolic derangements. I think they're very, very prominent and very unusual. And so if we just try to organize ourselves, David, in the 2 problems, and I think we got clarity on one of them. This person has a focal infiltrate and a leukocytosis. That should tell us that there's a high chance this person has community-acquired pneumonia, except that we didn't get any symptoms to help us understand what the time course is, because the only thing that's missing is the time course of a few days of symptoms, which you can say that maybe his 2 days of generalized weakness is that. And if that's true, then you're like, okay, community-acquired pneumonia, done. Anytime that you have community-acquired pneumonia and you have prominent extrapulmonary symptoms, you should really think about the possibility of the atypical organisms. The reason for that is the atypical organisms, Legionella, Mycoplasma, Chlamydia, etc., have a high rate of extrapulmonary dissemination compared to the normal flora. And here, the CK, the AST, the ALT are fingerprints of possibly extrapulmonary spread, as would be characteristic of Legionella. But I think the most interesting thing is then to study the next element we said, which is the electrolytes. And we have hyperglycemia, acute kidney injury, AST, ALT, CK, and low calcium. So many of them. And the real question is, which one do you start off with? What's your lead? And for me, I'll explain why it's the calcium. It's really driven by base rate of unusual nature. Glucose, hyperglycemia from diabetes with resultant dehydration causing kidney injury, causing AKI and hyperkalemia is a very common and easy to see thread. And response to fluids will help us tease out whether that is a real or not. So that's going to hypothetically wash away. The AST-ALT difference suggests that the source of these enzymes is not the liver, but the muscle. And so the question now is we have a separate problem. We have now muscle stuff. But let's talk about calcium first before we talk about muscle. So hypocalcemia is relatively common in critically ill patients because it represents one commonly activated arm of the hypocalcemia schema. There's two arms. A deficiency in hormones, either vitamin D, much more common, or PTH. Hypoparathyroidism is much less common than low vitamin D. But the major other category that's much more common, especially in acute symptomatic hypocalcemia, is chelation. And calcium loves to be chelated by things. It binds to phosphorus, binds to albumin, binds to citrate, binds to ethylene glycol, binds to fat and saponification. It binds many, many things. And guess what else it binds? It binds muscle. And in many patients with severe rhabdomyolysis, the calcium is low because the calcium is chelated in the muscle. So it's really interesting to try to wonder, did this patient have much higher levels of CK before? And is the hypocalcemia related to muscle involvement? But there's also a little bit of a pattern here. And that pattern is going now finally to talking about CK. So this differential diagnosis for CK is all the way up to esoteria in the world of rheumatology. But the most common causes of CK elevations are medications, which we don't know, electrolytes, which we have prominent evidence of, and toxins. And the major toxin that won't show up on a eutoxin, won't show up on an alcohol level, is alcohol that was previously consumed. So for me, whenever I see hypocalcemia, pneumonia, rhabdo, AST, ALT greater than 2 to 1, I'm really wondering what this person's alcohol use pattern is and what that background is. In large part because that is socially complex for people to divulge and talk about, and it has massive implications for the next few hours as the risk of alcohol withdrawal is imminent and upon us. And one helpful marker maybe to look at the MCV, and if that's high, I would really be worried about that possibility. But now we have 3 things to track. What's the pulmonary stuff and what's the time course for that? That's going to be key. Tracking the causes of low calcium initially with the hormone analysis of vitamin D, more common than PTH, and then studying what happens to the CK with fluids would probably be my next steps. But I'm very, very intrigued. It's a very tough case to put together. All right, Mark, tell us more, please.
Awesome. So yeah, some things that we did in the next couple hours is that we did fluid resuscitate the patient, and the potassium, the creatinine improved a little bit. We also gave some calcium gluconate due to concerns for symptomatic hypocalcemia, and his myoclonus and mental status started to perk up a little bit after getting some fluids and some calcium gluconate. And then we also did start ceftriaxone and azithromycin. due to concerns for community-acquired pneumonia with, as mentioned, with the infiltrate and the leukocytosis as well. So that's kind of some of the first things we did. And then some of the labs that you guys requested, I'll say those requested labs, and I'll show you some imaging. So we got the vitamin D level was normal, and the PTH level was low at 5. Some imaging that we got a CT head, which is negative. He got an MRI in his brain that showed no definitive acute intracranial abnormality, but suspected chronic ischemia in the right frontal periventricular region, superior to the caudate. We got a right upper quadrant ultrasound, which showed hepatomegaly, but no surface nodularity, and a 1.9 centimeter left liver lesion. And we got a transthoracic echocardiogram, which showed normal LV wall thickness, but it was reported as moderately reduced LVEF because, again, the windows were tough for the ultrasonographer, but no regional wall motion abnormalities. And then a few days later, but I'll just include it here, he got a nuclear stress test, which showed no evidence of reversible ischemia and an LVEF of 36%.
Okay. There are more information that I don't know how to associate all with the case. First of all, the hypocalcemia and the low pH, I think puts us in the bucket of like the PTH low being the cause of hypocalcemia, and this could be from the parathyroid glands are not working, and in the absence of surgery or radiotherapy, I think of autoimmune pathology or inflammatory pathology. But I'm not making sense of infiltrative pathology now. So, well, I'm not sure, but keeping in mind also the polyglandular things, here, the hepatomegaly. We don't know how long has been here. This could be also a feature of infiltrative pathology, but I'm not making at this moment too much of it because well, just I don't know how to fit it with the rest of the case. I don't know if maybe any infiltrative disease, multi-system disease could explain it, but not sure for now. And the low EF we have ischemia. I don't know either. So I thought this would be initially a consequence and not like the hypocalcemia or something similar, and not a primary event. And I'm thinking all of these manifestations are due to an underlying multi-system disease that we are not finding yet, or any of these are not related, as we don't know the time course of many of these pathologies. What do you think, Rabih? I'm not sure.
Yeah, David, I think Mark is presenting an incredible case, really, really incredible. And I think we haven't done a breakout room in a while, but I think there's a lot of abnormalities here, and I'd love for people to talk about them. I think that with your initial statements, I think you're on the right track. In my opinion, I have no idea with confidence what's going on, but I think there's a pattern that's emerging. So to give you more time to sit and think with it, I'm going to create some breakout rooms. For folks who are joining us for the first time with a breakout room, feel free to jump in and just listen in. But we really like for you to put your brain power together and chat as a group. We'll keep them for just 3 or 4 minutes. So just jump into the conversation, and when we come back, I'll share my thoughts and I'll see what you have to add after having some time to think, David. Okay? Sound good? All right, y'all. And if you prefer not to join, no problem at all. Just hang out here. I'm going to pause the recording so folks on YouTube can relax too. Hello, folks. I was just talking to myself for the last minute, by the way, on mute. I hope you enjoyed that. I think we don't do it as often, but we really want you to get to know each other as much as you possibly can and make some connections and reach out to people and get to know them personally. But David, the reason I stopped is because I completely agreed with the theme that you're on. And if we just kind of put the common things aside, the common things being community-acquired pneumonia, and analyze the unusual things about this case, is that this person seems to have diabetes that's new and hypoparathyroidism that's new. And we've diagnosed hypoparathyroidism because the PTH is unusually low despite the marked hypocalcemia. And so I'll just share that it's a very productive world to ask why this patient has multiple simultaneous endocrinopathies. But it's only a productive exercise because this patient has an unusual endocrinopathy, namely hypoparathyroidism. You shouldn't do this exercise if you are combining hypothyroidism and diabetes. They're both very common, and so odds are that they're true, and unrelated. So, David, if you were just to ask yourself what causes of an multiple endocrinopathies a patient might have, you immediately went appropriately into the likely scenario that the patient might have a genetic endocrine issue. So I'll ask you to think about if you can reflexively think of any acquired causes, non-genetic, because of this patient's age, that cause polyendocrinopathy. But I want to give you a minute to do that. And in the meantime, I'll just share the general approach to hypoparathyroidism, which is uncommon. Vast majority of hypoparathyroidism is iatrogenic after thyroid or neck surgery. It's because we accidentally removed the parathyroid. And an important second as a temporary transient cause of hypoparathyroidism is hypomagnesemia. Magnesium is critical for parathyroid hormone synthesis and action. So low mag and surgery are by far and away the most common causes. Then after that, you get into rare and esoteric genetic diseases and autoimmune diseases. I'll leave it at that as the kind of initial first pass. But if you see hypoparathyroidism, your first question to the patient is, have you had any neck surgery? And your next question is, what is the MAG level? After that, it becomes a whole slew of less common conditions, including genetic ones, autoimmune ones, and other acquired diseases. So David, any thoughts on how a patient might acquire multiple endocrinopathies, a non-genetic form? I think, yeah, you're muted. Just like me, we're tag teaming the mute button today.
Okay, sorry. I was just thinking that I felt like this seems to be like, multi and polyendocrinopathies, and or it could be infectious disease causing endocrinopathies. And now I thought, well, hemochromatosis could cause both in the same way, like polyendocrinopathies and being kind of infectious. So well, this is the only thing that I can do. But yeah, well, I think maybe there are also possible diseases that could cause underlying amyloidosis, and that would infiltrate in various organs, but maybe hemochromatosis is
I completely agree with you. This disease is starting to really look like hereditary hemochromatosis. And in large part is because when you have acquired endocrinopathies, the general approach to acquired endocrinopathies is to really think of two common things and one rare thing. The two common things are pituitary adenoma. So if you have a pituitary adenoma that's secreting one substance and compressing, causing deficiency of others, that can cause polyendocrinopathy. The rare cause is POEMS syndrome, and by definition, the E in POEMS is having multiple endocrinopathies. But I think one really important cause of multiple endocrinopathies is hemochromatosis, which is a great explanation for the parallel cardiac disease, the parallel liver disease that the patient has, the new onset diabetes, and also the propensity for infections. So the truth is here, I think what you really should try to solve, what you really should focus on is fixing the patient's pneumonia. What you really should try to work on to get to the bottom of this case is what the hypoparathyroidism represents. And one important category is heavy metal infiltration. And heavy metal infiltration by iron is really important, but also by copper. So Wilson's disease is another well-described, but here I think it's much more compatible with hemochromatosis. So yeah, I think thinking of Tansu, I think a ferritin would be a really nice, elegant next step, and a percent SAT, but it's a leap. I think the answer lies on the hypoparathyroidism schema, but hemochromatosis is prioritized simply for the reasons that David picked up on. All right, Mark, tell us more.
I promise I didn't tell my breakout room the answer, by the way. I was telling them though that for like 5 straight days, I was just like smiling in the call room as my then intern is just laughing at me as this data is coming back, because every test we ordered, as you guys see, came back positive. And every day we would go in the patient's room and he looked at me, he was like, "Doc, I know you're ordering another test today." I'm like, "Yep, we are." But moving on. So we got some more labs. So we got a TSH that was normal, an HIV RPR that was non-reactive. We got hepatitis serologies, which were negative. We had a B12 and folate, which was normal, an SPAP without any paraprotein, and then a ferritin of 414 and a TSAT of 76%. And the next test will reveal the final diagnosis.
Well, I think this could fit with hemochromatosis. And what the TSAT was 70 or
76. Very high.
Yeah, I don't know if it was 45 the exact number, but I think yeah, this could fit with hemochromatosis, and I think I don't remember the hemochromatosis. Also, there's a recent article on that I have to read, but I didn't read today. So I'm thinking, what is the next step? And the next step, I think it would be the genetic testing for this C2C. I don't know how it was like C 282 Y abnormality and H63D to test for that. I think. But if not, I don't know if another possibility is do like liver MRI to check for the uptake of iron in the liver. But yeah, I'm thinking of hemochromatosis.
Yeah, as you should, because I think you diagnosed that the patient has iron overload. The percent SAT should be repeated for confirmation because it's a noisy test, but the percent SAT diagnoses iron overload, and the ferritin supports tissue iron overload. And the question is, what causes iron overload? And there's really 3 big categories. The most common in the United States is that patients get blood transfusions. So we don't know much history about him, but asking him if he's ever gotten transfusions for any conditions before is going to be key. And that's the exogenous form of iron overload. The endogenous form occurs in the context of either liver diseases, for which a thorough alcohol history is probably going to be important, and then hematological diseases. Both the liver and the heme system either in the CP450 system in the liver, and then iron synthesis and hemoglobin synthesis. And so he doesn't have a hematological disease like MDS based on our data. He doesn't have overt liver disease, but alcohol consumption can really, really fool you. And it's really, really important to assess for secondary causes of iron overload because of one fact. And that fact is that genetic hemochromatosis is only penetrant, causing clinical hemochromatosis in 20% of patients. So even if Mark tells us that his genetic testing is positive, the only way we will know that that genetic testing is causing a phenotypical hemochromatosis is if we exclude other causes that are making it worse, like alcohol use. So remember, if you just know about a patient that they're genetically positive for hemochromatosis, you only know they have a 20% chance of developing the clinical syndrome. So 80% of people with genetic hemochromatosis either don't have iron overload, or if they do, they have it for another reason. So what would I do next? I would send off the genetic testing for hemochromatosis, but a thorough history about alcohol use is really important. Ultimately, the best diagnostic test is response to phlebotomy. Patients with non-hereditary hemochromatosis causes will develop anemia with phlebotomy, in contrast to patients with hereditary hemochromatosis, which won't. So yeah, I completely agree with you, but I would say that the biggest piece of advice is that hemochromatosis, the genetic testing is required for the diagnosis, but is not necessary. Parallel analysis of other causes of iron overload are really, really important. All right, Mark, tell us what y'all did.
Yeah, so the next test that we got, so we got a couple tests. So we got an MRI of the liver, protocol for iron overload, which showed increased uptake in the liver and spleen without findings suggestive of cirrhosis. And that left liver lesion that I mentioned was characteristic of a hepatic hemangioma, no findings concerning for HCC. And then we got the HFE genetic panel, which he was homozygous for the C2A2Y mutation.
Oh my gosh. David, what do you think of this case?
Very awesome. Thank you so much, Mark, for bringing it. So, what a complex case, because well, it had many twists, and I was thinking that this is so difficult to diagnose. Maybe well, because it's a multisystem disease, and maybe because the reserve of the liver is so much that most of the times we get to these patients when there is very advanced disease. Also in patients with cirrhosis, it's not uncommon to diagnose them with in a very advanced stage. So this is makes us go through patients that have other systemic involvement apart from the radical one, and that makes also everything more complicated. I was thinking of that.
Oh, sorry, I couldn't tell. I couldn't agree more with you. I think this is the most sneaky presentation of hemochromatosis I've ever seen. Now, often it's, yeah, I'll just leave it at that. I feel like I've talked a lot, and we did the breakout rooms. I want to respect everybody's time, and I want to make sure we hear from Mark. But I've come across many hemochromatosis cases in real life and in practice life, but this is by far the sneakiest way it has shown up. And I would just say that, like, many people would have missed this because hypocalcemia, like we said, is just so common and so unrelated. I think the key test here for me was, and the only time I thought about it was, oh, you have acquired non-surgical hypoparathyroidism in a patient with diabetes. And I've developed that reflex just from practice. But to have that reflex and not to have yet graduated from residency is bonkers. It's so cool. So more importantly, Mark, tell us what this felt like for you as it unfolded and what you learned from it.
I mean, thank you so much for your guys' discussion. I mean, this case is just like beautiful. I just really love this case. I kept telling my team, like, this is a case of hemochromatosis, which presented as symptomatic hyperglycemia and symptomatic hypocalcemia. I mean, that's just wild. I can't believe that that's how it presented. And I think it just really highlights the importance. I kept telling my intern Robert that, like, especially when a case has so many abnormalities like this, just be like a splitter on day one. Just make sure not to try to lump two problems together and think they're related, and just have, when you're making your problem list, it's, symptomatic hypocalcemia, symptomatic hyperglycemia, new HFrEF. And then once you're creating your differential and you realize that hemochromatosis not being the top of the differential of all those things, but being somewhere, then you're like, after you roll out all the common things, that, it does actually fit well. And I think really the only way I got there is, usually, and this is just a reflex for me, we're all new patients with heart failure with a reduced ejection fraction. I'll usually just order iron studies, just one, because, there is some data that, giving IV iron for heart failure does show some symptomatic improvement. And two, hemochromatosis is on the list. Now, it's usually a restrictive cardiomyopathy, but, rarely it can kind of be a dilated cardiomyopathy. So it didn't fit perfectly there. And then on day one, also, I told my team, I was like, like new diabetes in a 62-year-old, that just, something doesn't sound right about that. I know, obviously diabetes being very common, but as patients get older, I told my team, I was like, let's just make sure that there's no secondary causes of diabetes kind of going on here. But yeah, this was just an incredible case. I learned so much from you all.
I mean, I think it just speaks to your tremendous diagnostic acumen, but also your regimented approach. And I think we don't talk about being regimented enough. Talk about just creative thinking and really cool connections, but like a rigor is required of that. And like your rigorous approach to how you take care and how you diagnose patients with new heart failure, you get a % sat and iron studies every time. And your rigorous approach to analyzing the context of this patient's diabetes is really, really cool. And I think we can all tell that you're on a robust path to being a very, very shrewd diagnostician in this case. Like cracking this case, I think, is just visible proof of that, both for you and for David. Because if you guys notice, I didn't tell him. I didn't tell you, David. I just, like, you were picking up on the theme that there's an endocrine issue all along. And I think sort of like reflections and guided questionings got you there. So kudos to you both. This is really, really cool. And kudos to the entire supporting crew that made this happen with, I saw Shema, Deborah, Aisha, and Ashutosh all like taking the scribing for an incredibly complicated case, and maybe some others that I missed. So thank you all. I owe Francisco a little bit of an apology. I actually have to go to work to make it on time for my shift. So Francisco, I made you the host. You are now the king of this this VMR. I'll check out your teaching points later. So take it away, and please, Francisco, end the meeting when you're done, so we don't have insight into your thoughts after the VMR.
Okay.
Bye.
Bye, Rabih. Okay, everyone. This was an amazing case put out by Mark. Amazing collaboration, writing, scribing, the reasoning on the chat, the reasoning of David, of Rabih. It was truly amazing and very educational. So we had a patient with 2 days of generalized weakness and lower extremity edema, numbness, and also polydips and polyuria. We need to point out that we need to assess the time and see how all these are related, but immediately a neurological cause with rapid evolution popped up on our minds, and we started to think about electrolytes. And one thing that was an interesting teaching point was that a common neuropathy usually presents with the 3 S's. It's either most commonly symmetric, sensory predominant, and it's slowly progressive. However, when in our case, this was a fast progressive neuropathy, which would make us lean to an atypical presentation. And given this atypical presentation, we really needed 2 data points, which were the reflexes. And if the patient actually had none, it would be Guillain-Barré syndrome until proven otherwise, and we would also need to check the glucose to assess for diabetes mellitus. Besides that, it's really important to really observe the scene and see the patient. When the resident went to see the patient, he was actually very sick. He was desaturating. He had myoclonus. He was confused, carpal pedal spasm. And this brought us to a very interesting realization, which was that there were actually two dimensions to this case. A metabolic one and an hypoxemic respiratory failure one. So in terms of the metabolic, we started thinking about hypocalcemia because of the spasm mostly, and we highlighted the importance of having a ABG and EKG. And while on the other hand, with the respiratory failure, we needed to assess signs of infection and volume overload. And actually, after an X-ray, the patient really showed a consolidation and leukocytosis. So we started to think about maybe that he has clearly an infection, but probably from an atypical organism that may be spreading extra pulmonarily. And then when we got some other labs, we assessed that the patient had high blood sugar, low calcium mainly, and then we started to think about causes of hypocalcemia, which were mainly three broad categories. So deficiency of vitamin D, the deficiency of PDH, or more commonly in the acute setting, chelation. And actually, the patient had a very low PTH. So when we have a patient with very low PTH, we need to mainly ask two questions. What is the magnesium? And then if he had previously neck surgery. Of course, there are also a few other genetic and other autoimmune diseases. And we also started considering quite early in the case the possibility of the autoimmune polyglandular syndrome. After that, we went to the breakout rooms and we started shifting more to what are the causes of these multiple endocrinopathy. The patient had high blood sugar, low calcium, and we started thinking about pituitary adenoma, Poems syndrome, Wilson disease, and we then remembered that the patient had an hepatomegaly. And dilated cardiomyopathy, which made us lean more to an hemochromatosis as an infiltrative disease. We then checked the iron studies, which were elevated. The patient had iron overload, and then we started considering which could be the causes of iron overload. Transfusions, liver disease, hematologic disease, myelodysplastic syndrome, myeloproliferative syndrome, and then we have the genetic diseases, which would confirm, in which includes hemochromatosis. But we must pay attention that it's a disease with low penetrance, so patients may have a positive genetic test, but even with a positive genetic test, we must exclude other causes. And an interesting testing is using phlebotomy to distinguish from hereditary to non-hereditary causes. The patients that have hereditary causes don't develop anemia, while the other ones do develop it. So the patient did have a positive genetic testing, and the last and the final diagnosis was hereditary hemochromatosis. So thank you so much, everyone. I hope you learned a lot. Okay. See you soon, guys. It was a pleasure. See you tomorrow. Enjoy.
Bye.